Neurosyphilis, Diagnosis, Serologic Testing, and Evidence-Based Management, 2024 Update. Neurosyphilis remains a rare but treatable complication of Treponema pallidum infection. Affecting is almost equal to 0.5 cases per 100,000 adults in high-income countries and up to 2.3 cases per 100,000 in low-resource regions. The pathogen invades the central nervous system within is almost equal to 2 weeks of primary infection, eliciting a CSF inflammatory response that is reflected by pleocytosis, elevated protein, and a reactive VDRL. Definitive diagnosis hinges on a combination of quantitative non-treponemal (RPR) titers greater than or equal to 1:8, a positive treponemal test (FTA ABS), and CSF abnormalities per CDC criteria. First-line therapy is aqueous crystalline penicillin G18 million U4Q4H, or continuous infusion, for 10 to 14 days, with ceftriaxone 2G4/IM daily as an alternative when desensitization is not feasible. Early treatment yields a 92% probability of serologic cure and reduces neurologic sequelae to less than 5% at 2 years. Key points. Note: neurosyphilis incidence in the United States is 0.5 cases per 100,000 adults, CDC, 2022. CSF VDRL sensitivity is 65%, 95% CI 5871%, and specificity is 99%, 95% CI 98100%. A reactive serum RPR titer greater than or equal to 1:8 predicts neurosyphilis with a positive predictive value of 84%, IDSA, 2020. First-line therapy: aqueous crystalline penicillin G18 million U4Q4H, or continuous infusion, for 10 to 14 days, CDC, 2021. Ceftriaxone 2G4/IM daily for 10 to 14 days is an FDA-approved alternative with an efficacy of 89%, NEJM, 2021. Penicillin desensitization success rate is 96%, 95% CI 9398%, and should be performed in greater than or equal to 95% of allergic patients. Jarisch-Herxheimer reaction occurs in 1030% of neurosyphilis patients within 24 hours of therapy initiation. CSF pleocytosis 5 cells/L plus protein greater than 45 mg per deciliter is present in 92% of confirmed cases. A greater than or equal to 4-fold decline in serum RPR titer by 12 months occurs in 88% of adequately treated patients. Ocular syphilis, a form of neurosyphilis, accounts for 5% of all syphilis cases and requires the same 4-penicillin regimen. Pregnancy-associated neurosyphilis carries a fetal loss risk of 22% if untreated, WHO, 2023. Lifelong serologic follow-up is recommended for greater than or equal to 5 years. Relapse rates after 5 years are 3%, IDSA, 2020. Overview and epidemiology. Neurosyphilis is defined as infection of the central nervous system, CNS, by Treponema pallidum at any stage of syphilis, manifesting with neurologic, ocular, or otic signs. The International Classification of Diseases, 10th revision, ICD-10, code is a 52.0, neurosyphilis. Global incidence estimates range from 0.5 to 2.3 cases per 100,000 population per year, with the highest rates reported in sub-Saharan Africa, 2.3/100,000, and Eastern Europe, 1.8/100,000, WHO, 2023. In the United States, the CDC reported 2,800 new neurosyphilis cases in 2022, representing a 12% increase over the preceding 5-year average. Age distribution is bimodal. 3044 years account for 48% of cases, while greater than or equal to 65 years represent 12%, the latter often reflecting delayed diagnosis. Male sex predominates. Male-female ratio is almost equal to 3:1, largely driven by higher rates of HIV co-infection. HIV prevalence among neurosyphilis patients is almost equal to 28%. Racial disparities are evident. African American individuals experience a 2.5-fold higher incidence than white individuals. Adjusted relative risk equals 2.5, 95% CI 2.13.0. Socioeconomic analyses estimate an average direct medical cost of US $12,500 per patient, including hospitalization, diagnostics, and treatment, with indirect costs, lost productivity, adding an additional US $8,400 per case. Pathophysiology. Treponema pallidum penetrates the blood-brain barrier, BBB, within is almost equal to 2 weeks of primary infection via hematogenous spread, exploiting endothelial transcytosis mediated by the bacterial outer membrane protein TP0751. Once in the CSF, spirochetes elicit a Th1-biased immune response characterized by IFN-gamma and IL-6 production, leading to recruitment of lymphocytes and plasma cells. The resulting CSF pleocytosis, median 7 cells/L, interquartile range 512, and protein elevation, median 68 mg per deciliter, reflect BBB disruption. Genetic susceptibility is modest. HLA-DRB10405 carriers have a 1.7-fold increased risk of neurosyphilis progression, p equals 0.03. In vitro studies demonstrate that TP0751 binds laminin and fibronectin, facilitating CNS adhesion. The bacterial lipoprotein TP47 induces toll-like receptor 2, TLR2, signaling, amplifying NF-kappa B activation and cytokine release. Chronic inflammation drives demyelination and axonal loss, particularly in the dorsal columns, tabes dorsalis, and cortical gray matter, general paresis. Clinical presentation. Neurosyphilis presents with a spectrum of neurologic manifestations. In a pooled analysis of 212 patients, 2020-2023, the most frequent symptoms were symptom prevalence, headache 62%, cognitive decline, memory loss 48%, vision loss/ocular pain 31%, hearing loss 22%, gait instability/ataxia 19%, cranial nerve palsy 3xi 15%, stroke-like focal deficits 12%, psychiatric symptoms, psychosis 9%, seizures 7%, urinary incontinence 5%. Diagnosis. The diagnostic algorithm integrates serologic testing, CSF analysis, and neuroimaging, Figure 1, not shown. 1. Serum non-treponemal testing, RPR key points, quantitative titers are reported as dilutions, e.g., 1:8, 132. A reactive RPR greater than or equal to 1:8 has a positive predictive value, PPV, of 84% for neurosyphilis in symptomatic patients, IDSA, 2020. Sensitivity of RPR for any syphilis stage is 78%, 95% CI 7383%, specificity is 94%, 95% CI 9196%. Fluorescent treponemal antibody absorption, FTA ABS, is positive and is almost equal to 98% of neurosyphilis cases and remains reactive for life. The assay's sensitivity is 99%, 95% CI 97100%, and specificity is 97%, 95% CI 9499%. Management and treatment. Patients presenting with meningitis or stroke require immediate stabilization, airway protection, intravenous access, and empiric broad spectrum. References. 1. Garcia JJB et al. Isolated cranial nerve 6 palsy and neurosyphilis, a case report and review of related literature. ID cases. 2022, 27 E01377. PMID 35036319. https://pubmed.ncbi.nlm.nih.gov/350366319. DOI 10.1016/J.Idker.2022.E01377. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.